afternoon, everybody. My name is Carolyn Karger, and I am with COA. And today I am super excited to have a conversation with a member of our community, and his name is Dr. Lou DeMaria. Hello, Dr. Lou DeMaria.
Hey, good afternoon.
Thank you so much for having a conversation with me today.
You're welcome.
I understand that you are a primary care geriatrician.
Yes, that's correct. Mm-hmm.
Would you mind telling us what geriatrics is?
Sure. Geriatrics is the clinical care for folks who are aged. It is a discipline that embraces a body of knowledge that probably began to evolve in the 1980s. And then has really developed into a kind of a subspecialty. There's a special certification that many of us in primary care in either family medicine or internal medicine become specially certified in geriatrics. You have to take an exam and you have to have certain qualifications and stay current and get recertified. And that really kind of legitimatized the discipline of geriatrics since probably 1985, 86.
Okay, so that seems super valuable to the people who participate in COA and COA's programs. What inspired you to go into that specialty?
Well, it was back in the early 80s. I just had come out of the Air Force and did my Air Force obligation. And I had already finished my training in primary care and family medicine. And I was teaching at a family medicine residency. And I became aware of a book that was published on the topic ageism by Dr. Robert Butler. Bob Butler was a psychiatrist. He died about, I guess, 6-7 years ago. Bob Butler is basically the father of geriatrics. He coined the phrase ageism. He wrote a large book about the discipline and really described the need to study more about the biopsychosocial aspects of geriatrics. In other words, the medical issues of aging, but also the psychiatric, the mental health, and the sociologic issues of aging as well. And given as a psychiatrist, he was very well positioned to comment about that. So I read his book and became involved in finding more out about the discipline. And I really wanted to add more credibility to my academic career. So I applied to a number of fellowships in geriatrics. And was fortunate. I was interviewed by Bob Butler at Mount Sinai because he was at Mount Sinai in New York City for many, many years.
Wow.
And he interviewed me, and that was kind of a very interesting highlight of my career. But I didn't decide to match with Mount Sinai. I went to Duke University and spent 2 years as a VA fellow there, and then stayed on again as assistant professor for an extra year.
Oh, wow. Okay. So did Dr. Butler have, what exactly is ageism, if you don't mind?
Well, ageism, to put it very, very succinctly, is all the biases that people carry around with them vis-a-vis a chronologic age. For example, if all of us have grandparents, if you look at your grandparents and maybe the individual becomes a little forgetful, or maybe is stumbling a bit, they say, well, that person is just getting old. And that's basically ageism, when really what we should be doing is asking ourselves, why is the person stumbling? Why is the person falling? Why is their intellectual capacity starting to deteriorate? And that's when we became more aware of the prevalence or the significance of dementia in our population. Most specifically Alzheimer's dementia.
Okay, so it was geriatrics that got involved. It was that study that got involved in determining what's happening with Alzheimer's and what's causing it.
I think it really pushed all clinicians to begin to think of not labeling loss of memory as senility, but what is the cause? Can it be treated? What are the medications that make it worse? What are the medications that make it better? And then foster research in that area.
That's really interesting. So I know that there's something called gerontology.
Right.
And what is the difference between gerontology and geriatrics?
Geriatrics is more the clinical application of the body of knowledge, and mostly that's what physicians will use. Gerontology is a basic science, like anatomy or physiology or pharmacology. It's usually studies the sociology of aging. Many researchers in gerontology are psychiatrists or psychologists or even social workers.
Okay.
And they'll study the sociology of aging, the problems associated with loneliness and depression in late life, and how congregate housing is important in late life, and all those sociologic related issues. So it's a basic science that supports the clinical medicine of geriatrics.
Okay, so I have never met a geriatrician before. Okay. So what is the population like? Is it a small population of geriatric doctors?
Oh yeah, there's probably maybe 8,000 or 9,000 geriatricians in the country.
Wow.
And the number graduating from fellowships each year is a couple hundred. It's really, really low. There are a few in this area associated with Flagler or Baptist or Mayo, but they function primarily as consultants. And I can give you an anecdote of a consultation if you'd like. I could tell
Sure.
you how that would fit into, say, somebody watching this interview, mm-hmm. and how a geriatrician might help them. Is that
Sure? I'd love to learn that. Yeah.
And the anecdote is true because it really involves my dad.
Okay.
I hadn't seen my dad for a number of years because I was busy with my practice and our traveling and all the different things I was doing in my academic life. And when I visited him at his beach house on the Jersey Shore, naturally, one thing that we usually do is you cook outside on the grill. So we opened up the grill and the grill didn't fire up, it didn't light. And I noticed that there was a hole, a rent in the tubing leading from the tank to the burner. Now, you got to understand, my dad was a World War II vet. He didn't have any formal education, but he was a self-made man. He could do anything. I mean, when I was a senior in high school and I was going off to college, he bought me a 57 Chevy and we took out the old engine and put a new engine in. Wow. And he was that kind of a guy, okay? Mm-hmm. So for me to turn to him and say, okay, Dad, we have to fix the grill. What do you think is wrong? He looked at me quizzically and he had no idea of what to do. No idea at all. And he was really getting quite disturbed by that. And so naturally we went to the hardware store, we got the tubing and replaced the tubing and everything. So I talked to my mom a bit after that, and I was concerned because I had just come out of my fellowship and I was very aware of how this kind of lack of functioning, if you will, or change in functioning can be a harbinger of a problem. So I really insisted that she go to a local geriatrician, and there was one at a major hospital system in northern New Jersey, and he was diagnosed with Alzheimer's dementia. She took care of him, watched him carefully at home for probably the next 5 years, and then he ended up in a nursing home and finally died peacefully at a VA nursing home. So the point of the story is, if you brought up the issue that you're dealing with your own doctor and maybe things are not working out to your satisfaction or you have questions, And if there are issues related to either medications or intellectual capacity or mood, or risk for depression, or the person is falling or incontinent, in other words, wetting oneself all the time, urinary incontinence, those are all things that a geriatrician would be very happy to evaluate. But here's the key. The key is that geriatricians don't work alone. And it was very hard for me to do that in my primary care practice. They work as a team. And in our team at Duke, it was usually a nurse or a nurse practitioner, a social worker, and sometimes we had even a neuropsychologist who helped us with neuropsychologic testing. But most geriatricians at least have a nurse and a social worker evaluating the comprehensive situation involving the member, the patient, looking at their family situation, their living situation, their resources, their mood, their mental status, as well as their medications and their physical examination and their clinical status, whether they have diabetes, high blood pressure, et cetera, et cetera.
I see.
Does that answer your question?
It does. It really, really does.
Okay.
So when you were working in your practice, did you see primary care patients, and then if some of your primary care patients were elderly, did you then serve as their geriatrician too? Or was it mainly as a consultant with other specialists?
When I left my fellowship, I went to Lancaster, Pennsylvania, and I worked for a large hospital system there. And I did teaching of the residents. I did rounded with the residents. We went to the nursing home. We did a lot of academic things, but I also on the side started a primary care geriatrics practice. I see. Which was very, very tough on me and very, very tough on my family. We had a young son. My wife was pregnant. I wasn't home very much. Yes, I did primary care. I took care of people that were well elderly. In other words, people who were relatively healthy, 65, 66 years old, and doing very, very well as individuals who were 80, 85 in a nursing home, demented, being cared for at home, needing house calls, all that kind of thing. It was a tough 2 years for me.
Yeah. So this is a relatively recent sort of medical revolution that, if you think it was the 1980s, you said, when right. Dr. Butler first created the programs.
Well, he coined the phrase, and then after that, a lot of academic centers began to develop centers for geriatrics and then fellowships that were associated with geriatrics, usually, again, associated with primary care training programs. I was fortunate to get one of the first ones. Duke had just had a center for aging. They did a lot of aging research. And Sinai also was one of the leaders as well. And my old chief actually was not a geriatrician by training. He started as a hematologist oncologist, and then he got into geriatrics for the same reasons I did. And he still did very basic science research on cellular aging, how our cells age. But many of us were, in our group, we had a couple of primary care docs. We had a rheumatologist, and we actually had a dermatologist and a physiatrist, person who's in physical medicine. So we had a very diverse group, but that began to spread. And now I think most medical schools have either departments or sub-departments of geriatrics.
That's great. So would it be fair to say, I've heard other, maybe gerontologists said this, I'm not exactly sure, but say that they don't view aging as a disease. They view it's just a natural process. What's your take on that idea?
Aging is a natural process, and that encompasses a lot of what gerontologists study. Quick example, as we age, our kidney function linearly, in other words, in a straight line, declines. So based on your sex, your age, your body weight, you can kind of estimate what your renal function is. That's why medications that are cleared or excreted or eliminated by the kidney the dosage needs to be adjusted very, very carefully based on one's age. So if you're 85 and you're taking a drug that is excreted to the kidneys, you may need half or even a quarter of the usual dose.
Wow, that's fascinating. That's really interesting.
So the aging studies, that's just one example of one organ system, but researchers will look at aging of the eye, the lungs, the heart, the gastrointestinal system, all our systems. And then there are bodies of knowledge that we could talk about in the future, I guess, yeah, which can tell people what effects of aging are occurring in their own bodies, but then have to layer on top of that what disorders that they're dealing with. If they're diabetic or they have bad lung disease or they have cancer, that adds a whole extra layer of concern on top of the basic aging of those organ systems.
So one of the things that everybody, I think, universally is interested in is what they can do, I guess, to keep their functioning at a better level. Are there things that people can do to prevent sort of a steep decline in functioning as we get older?
Well, I'm glad you mentioned the word function, because that's kind of the byword that all of us in geriatrics live by. I'm not so much concerned about all the diseases that people have, but I'm concerned about what they can do and not do. Most geriatricians we live by understanding what the basic activities of daily living are and the instrumental activities of daily living. In other words, if you're not able to use a telephone or handle your finances, that's a huge red flag. Mm-hmm. Okay, and that could indicate some decline in intellectual function. If you have trouble getting to the bathroom or have trouble bathing, those are even more serious because they involve the basic activities of daily living. And then what a geriatrics team would want to look at is, why is that happening? What can we do to improve function? And what are the things that are contributing to them, whether it be one's diabetes, one's high blood pressure, heart disease, or medications. Most of the time, in the geriatric clinic when I was a fellow, medications were at the top of the list, always. And we stopped most medications, particularly with people who had some kind of intellectual impairment.
Really? That's truly fascinating. So did you notice improvements, or did you notice a slowing of the progression of the problems?
It depends. If most people would improve, or they would clear, in other words, the drugs would be eliminated from the body, but then you would basically see what the underlying condition was like, whether it be a dementia of the Alzheimer's type, or whether an individual was perfectly normal. And there are good examples of individuals, when the drugs washed out, they became perfectly normal. So those really drove home to all of us the need to look at medications.
Yeah, I am aware of people being on multiple medications, and you just know that the studies on combining every single medication with every other single medication just can't physically be done. So it makes sense that in a clinical setting that you, as a scientist, as a doctor, would sort of see how adjusting those medications would influence your patient's health.
Well, not only that, there are situations where a medication is given and a side effect occurs. And then instead of stopping or decreasing the initial medication, a second drug is added to deal with the side effects. And that just keeps going round and round and round. And then before you know it, you've got an individual who's on 15, 20 medications when they only need maybe one or two. So that's why a lot of times what a geriatrician will do is only keep on the medications that are absolutely needed and then very, very slowly, if it was appropriate, to very slowly wean that individual off the drugs if they feel that that's contributing to the underlying problem.
Wow, that is fascinating. And when you explain what's happening with the kidneys and the organs that need to detoxify and flush out these substances, it really makes sense.
Right, right.
So that's really amazing. Now, are you retired now?
I am retired. I stopped doing my clinical work in January of this year.
Oh, wow. So it's very recent.
Yeah.
How is retirement treating you?
Well, the first couple months, honestly, were rugged, were really tough. But I've adjusted now, and I'm looking to do many, many other things, fishing, arts and crafts, and certainly when the COVID pandemic is over, traveling will be at the top of the list as well, because I need to see my kids more often, and we need to travel.
Yeah. Well, when did you come to Florida? So you were practicing, you said, in Pennsylvania?
Well, that primary care practice lasted 2 years, and it became so uncomfortable for us as a family that I went back into academic medicine.
I see.
And once one particular job was in southern New Jersey, and another job was in suburban Philadelphia. But the last 15 years or so, I've been working with Medicare managed care. Okay. For basically insurance companies.
Okay.
There are many needs in terms of care management for people on Medicare. And I've spent a good amount of time working with nurses in care management and how they support all the membership of people, largely over 75, and very complex individuals on 20, 25 medications and 8 diseases, and in and out of the hospital all the time. These are very, very complex, very, very sick people.
Oh, wow. Wow. So have you had a presence in Florida for a while?
Well, we arrived here about 6 years ago, and I worked for the first 4 or 5 years telecommuting, just working on my computer and working with the nurses and the patients that they were helping.
So you're way ahead of the curve. So when COVID rolled along, you were already well established in this virtual workspace.
Kind of, yeah. We didn't use video much. We used mostly audio, but online lectures I would do and review of cases, we did that all the time with the nurses. It was a standard operating procedure, yeah.
So one of the questions that people have, and I apologize to anyone who's watching right now that we can't answer any of the questions or the things you might be interested in. If you would please just type them in on Facebook and let us know. And then in the future, we could address them. Right now we're on I think a 4 or 5 second delay, so we can't monitor them. But one of the things that I've been asked, and I know that people are interested in, especially now, is if you have any advice on how elders and seniors living in Florida can be proactive in pursuing good health.
A good question, and we probably could use an hour talking about it. But
and maybe we will, maybe we will. But if there's anything,
well, I'll hit the high points. Exercise, nutrition, good primary care, and immunizations. In other words, I think to have a good primary care doctor is first and foremost, because that doctor can know what one's conditions are and how to manage those conditions and to screen for unforeseen conditions and complications. Go over the medications with your doctor on a regular basis. Exercise needs to be carefully looked at, because you can't just start to exercise automatically right away. You've got to maybe start with walking and then talk to your doctor about whether that's safe to do. And then if it's safe to do, maybe more brisk walking. And then if that's still safe to do and everything, and the doctor says it's okay, you could get an exercise prescription about whether aquatic exercise, swimming, or on an exercise bike. But you could ask your doctor, if appropriate, what's my target heart rate? And then your target heart rate, you can follow on an exercise bike, for example.
I
And
see.
usually the recommendations are for most people in middle age and late life, if you could get 150 minutes of moderate exercise per week, that's really a great start. Now, again, that needs to be tailored to your particular medical situation, because maybe you can't walk. Maybe you've got bad peripheral artery disease, or you've got heart failure, or coronary artery disease or something. But if your doctor agrees and you can set a target for 150 minutes per week, that would be great. It kind of comes down to, and that's what I basically use myself. If I go to an exercise club, which I can't now because of the pandemic, but I usually would get on the exercise bike for 20, 30, 40 minutes, and then use the free weights for a bit. And after that's about 40 or 50 minutes right there. And then do some biking around where I live here in a gated community in Ponte Vedra. And that I can get my 50 minutes in at least three times a week. That hits the goal. So that's exercise. Nutrition is really key as well. Leafy green vegetables, look at the basic requirements, nutritional requirements that the American Diabetic Association or American Dietetic Association has put together. A cornerstone of grains and a balance of all the different food groups. I think that's really key as well. Watch your saturated fats. And then immunizations. And certainly the flu shot is a cornerstone. Annual flu shot. The Prevnar 13, the Pneumovax, those are basic cornerstones of good therapy. There are now immunizations against shingles to prevent the pain of shingles. And hopefully we'll have a COVID vaccine for seniors sometime in the next 3 to 6 months. It probably will be more than one shot. But I think those would be the starting point issues. And then as you can get into all kinds of other things, such as loneliness and social isolation and how to deal with that, and mood disorders and a risk for depression in late life, which is a big problem, and how to identify the markers for those kinds of things.
So it sounds like it would be a good idea to be proactive and bring these subjects up with your primary care physician. So I know that since the pandemic, we have taken some of our exercise instructors' classes, and they have been kind enough to record them, and then we upload them to COA's YouTube channel, which everybody can access at any time. We have chair yoga, we have Qigong, we have regular yoga, total body fitness, Tai Chi, things like that. And I guess you could even show your doctor the videos, or, be proactive, it sounds, and have this conversation if it's really so important and so empowering to staying healthy.
Yeah, but I think just a word of caution about that. You really need to take the exercises and tailor it to the individual. That's why the exercise prescription is really key. What does your doctor think that is most appropriate for you? Maybe it's just walking, or maybe it's water polo, where you're non-weight bearing and you're in a pool. If in a lot of pools in Florida, or if you're fortunate to live in a gated community with an exercise club, maybe the socialization of water polo or aquatic exercises would be ideal for you. So you really need to tailor the exercise activity to the exercise prescription.
And you can talk to your doctor about that.
Oh yeah, sure.
Yeah. So that's a great idea. And we're really, really fortunate to live in Florida, where you're able to get outside if it's okay with your doctor, and get some fresh air, get some sunshine. We're not cooped up for like 8 months of the year, like it is in some states where it's really cold and icy. So that's great. Well, I would love to have you come on again, because I think the subject of ageism is really, really important and fascinating. And I would love to get your take on what that is. But maybe we could do that another time,
Sure.
Dr. Wu?
Sure.
Good, good. So I always like to ask, the reason for us having these conversations, the whole idea behind it, which I explained to you, was the idea that aging is has a negative in general connotation in our culture, at least in the United States. So we tend to be a very youth-oriented culture.
Right.
And even when I'm around
But
town,
that's changing. It's changing.
changing, right? Because
we're now seeing commercials for incontinence pads, right?
Right?
It's changing.
It's changing. We
Yeah.
have the boomers, the biggest generation,
Right.
and they're going to change the world.
Right. We're
and
going to
we
change the world.
That's right.
Yeah.
That's right. And so I would love to have a conversation about that. But this, the idea behind this is my own personal opinion that if we're here for a purpose. You know, we're not just withering away. We're actually still creative, powerful people, and we have work to do. Even if we've retired from the previous career, there's no reason why we can't have different and new projects and grow into new areas, you know, just like you're embarking right now, having just retired in January. I'm sure you have like a whole list of projects and things that you want to tackle.
I do.
Yeah. And I hope the COA community, you know, might fit in there somewhere where we can continue to have conversations to help people improve their health and maybe view the aging process in a more positive light. That would be super.
And maybe sometime in the future, we can actually all sit in the same room and not have to do it virtually. And that will be probably more meaningful to everyone.
Sure, absolutely. People cannot wait for that to happen. And in the meantime, we could even do it in a Zoom room with multiple people, not just you and I having a conversation. We could potentially do that if and when you have time.
Sure.
I like to end my conversations with this question. I'm going to skip to the second one, and then maybe we'll go back to the first, or maybe we'll do that one another time. But the idea is, if you could go back in time and give yourself, when you were 40 years old, a piece of wisdom or advice, can you think of what you might share with yourself if it were possible?
Well, it's a good question. And actually, it's very poignant to me because when my two sons were in high school, they went to a Jesuit high school in Philadelphia. And one of the requirements for seniors is that they go away on a retreat. And as part of that retreat, each parent had to write a letter to their son. It was an all-boys school. They had to write a letter to their son, and then that letter would be mailed to the program in a sealed envelope, and that would be opened only by the student when they were alone on the retreat. And we had to. It was a personal letter from each parent to that student, and it's poignant for me because my older son was born around the time that I was around 40, and as I reflect back on that, I think what I really would, and I said to him in the letter, I wish I had had the time to spend more time with him, particularly in the formative years when he was a toddler and a preschooler. I certainly got to know them both when they were older, and you know, in terms of being supporting them for soccer and scouts and athletics and all that kind of thing. But to be able to tell oneself to spend more time with one's children when they're preschool and when they're in the formative years is really, really key. And because of my busy career, I couldn't do that. My wife had to do that, and I regret that. But they know that now, and I shared it with them, and that's been therapeutic for me.
That's great. That's great advice. Yep, time goes quickly, and that's really excellent, poignant advice. The great news is we keep going on, and we can keep growing in our relationships.
Right. Oh, yeah.
So you're still here, they're still here, and you can continue to get to know each other and enjoy each other.
Yep.
I'd like to just tell everybody who's watching that if you have any questions for Dr. DeMaria that you would like us to ask him maybe in a future conversation, please, you can DM us on Facebook, and that will be private, or you can post them on this video. You can also email me at my email address at COA, which is ckarger@coasjc.org. That's CKARGER. And I would love to hear from you. And I would love to get some more questions for Dr. DeMaria, because we're so fortunate that we are able to talk to somebody who's devoted their life to treating older patients. So anyway, I look forward to hearing from everybody there. If anyone needs COA services, we have a wide variety of services that we are still offering to everybody, and you can find out more about them by calling us at 904-209-3700. And we also have two wonderful receptionists who are very warm and outgoing people who would be happy to chat, even if you feel like you just want to reconnect with the person and find out what's going on at COA. They're always happy to take your call. And if you want to find out more about our services, you can also go to our website, which is www.coasjc.org. I want to thank you so much. Thank you so much, Dr. DeMaria. It's been such a pleasure. Such a pleasure getting to know you and getting to know about this great work that you've been doing your whole life. And I really, really look forward to having more conversations with you, I hope.
Very good, Carolyn. Talk to you soon.
Thank you. Thank you, everybody. Bye-bye.
Bye-bye.